Welcome back. You're watching Daybreak. Thanks for staying with us. Dr. Samuel Mwenda is the General Secretary, the Christian Health Association of Kenya. Dr. Abdi Mohamed chairs the Social Health Authority Board. And Dr. Brian Lishenga is the chairperson of the Rural Hospitals Association, Hospitals Association of Kenya. Thanks for staying with us, gentlemen. Dr. Lishenga, to you. But after this soundbite by the acting Chief Executive Officer of the Social Health Authority, who appeared before the Senate Health Committee, chaired by Uasin Gishu County Senator Jackson Mandago, to shed more light on the contribution mechanism and the questions around how less Kenyans were contributing to the Social Health Insurance Fund. Here's what he said.
That will give us an additional 28 billion to add to the 2031. We already have to bring the total collections under shift to around 60 billion. We also expect to get an additional 3 billion for primary health and emergency, chronic and critical illness, 3 billion each. So it will bring the total to 7 and 5 billion. So as it is under shift, we have almost close to 5 million who are contributing. If I may just make it further clear, is that the 20.5 mark we are at today, the target is to have the entire population. And the entire population is not expected to pay, because within that population, we have those who are dependents.
Yes, Dr. Lishenga. I think that we have a problem with the source of funds. If you look at all the acts, especially the Social Health Insurance Act, let me just point specific issues that we have raised over time. Number one of the source of funds for the Social Health Insurance Fund, the one that they are talking about, is in clause 25. It says compulsory public, it says funds from the national government and county governments and their respective entities for the administration of compulsory public service employee insurance. So my interpretation here is that we are talking about public servants, civil servants. And a critical source of funds, which is listed there in Part D, is that the national government, county governments, and their respective entities are supposed to remit into the Social Health Insurance Fund. Okay. Now, we noted that at that time, there was no, the enhanced packages were being done away with. And therefore, in our understanding, these remittances are supposed to go into the SHA fund. However, as you know, there has been a lot of changes, and there seems to be an independent fund for civil servants. What we are concerned about here... Other than SHIF? Other than SHIF. And which is... and chairman is here, chairman of SHA is here, and he might comment on this, because ideally, according to the Act, the national government, county governments, and their respective entities, I imagine this include the SAGAs, the ministries, departments, and agencies, are meant to remit money earmarked for the compulsory public servants medical scheme to the SHIF fund. So in other words, that if you're a civil servant, or you're a county employee, or you are employed by a parastatal ministry or department, according to how we wrote the Act, that department, that parastatal, that county, that national government entity is supposed to remit funds to the SHIF fund. Now, that is one area where we are struggling as a source of funds. The other area where we are struggling as a source of funds is, if you look at the Act, and we mentioned this, when we look at both the emergency, chronic and critical illnesses fund and the primary healthcare fund, we noticed that there was a gap, and these are some of the things that we need to have a conversation as a country. We noticed that there was a gap in the funding for indigents, vulnerable, elderly, those who cannot contribute for whatever reason. Initially, our proposal had been that we should have a clear line so that we eliminate ambiguity. And you see, some of the issues we are dealing with are actually because of these ambiguities. We said that Parliament, while we have a parliamentary appropriation for PHC, and we have a parliamentary appropriation for emergency chronic and critical illnesses. It was our suggestion that we include in that act a line that there is also a parliamentary appropriation for PHC for indigents, vulnerable, and orphans, those who are not able to pay. Okay, we also wanted for the emergency chronic and critical fund a line that there will be a parliamentary appropriation for indigents, vulnerable, etc. Now, the challenges we are having is that for primary health care, if you are if you fall into any of those categories that cannot contribute, okay, you are now being thrown somewhere between county governments and national governments. Somebody is supposed to make the payments for you. And remember, we have now also made it a requirement that regardless of your status in life, you must go through proxy means testing if you are in formal sector. So these indigents, vulnerable, and teenage mothers, all this, this requirement for proxy means testing is meant to include them into the SHA fund, okay? Because if you are to look at it precisely, the primary healthcare fund is not, you do not benefit from it because you are a contributor. You benefit from it because you are registered. The Emergency Chronic and Critical Illness Fund, another appropriation by Parliament, is by being registered. But those two funds, we left a lot of grey areas in terms of how we operationalize them. Another issue we should mention is that...
What then happens? Because the acting CEO mentions that only 5 million are making their contributions. And that is... So how sustainable is it?
That is an issue that we have given alternative suggestions about. So, for instance, I think that the proxy means testing, is not the way to do it, because in a country where we have more than 60% of people unemployed, not in formal employment, it's good my colleague Dr. Mwenda here is appealing to Kenyans to contribute. I would also appeal to Kenyans to contribute because I understand Dr. Abdi requires the money, but I will, at the same time as I appeal to Kenyans to contribute and not just register, we would challenge government, challenge the Social Health Authority to revisit the model. One of the suggestions that has come out and it's been around for over a year, is that, for instance, we should have had an earmark tax so that every Kenyan also contributes through some form of, as you purchase goods and services, etc., you contribute. The problem we have is that when you calculate my premium and you make my contribution voluntary, then you have a problem. The other thing that we are missing, Abdi, Ayub, I should mention, is that when you look at the Act had created a premium financing mechanism. So, for instance, and that was a very good suggestion as part of, when we asked, what if people can't struggle, they say we have premium financing. And the Ministry of Cooperatives, MSMEs is supposed to be doing that. At this point in time, we have not seen any structure coming out of the Ministry of Cooperatives and MSMEs to support the premium financing. Last point I want to make on this. Everything, if you read the Social Health Act, every single step, the primary health care fund, the emergency chronic and critical illness fund, premium financing, claims management, every statement is followed by the term, the cabinet secretary shall create regulations to operationalize. We are having a problem because the cabinet secretary has been very silent on issues that require the office of the CS to create regulations. Like, for instance, the issue of how do you move from the SHA fund to the chronic and critical illnesses fund when the law says after depletion. If you look at the Act says that the minister shall create regulations that advise on how people move. To this day, as we are here, once you quote-unquote deplete your social health insurance fund, you have no way of moving because the regulation that is supposed to operationalize that is not in place.
Okay, and Dr. Mwenda, before we go to Dr. Abdi, to you now, because as providers, that's the last 10 million Kenya shillings not paid yet, is it?
Yes, we've not received that payment.
So what then happens, because PS Harry Kimtai says if you go ahead as you had done before to stop service provision, then that will have severe consequences, including the threatening of license renewal.
Well, the faith-based, just like other service providers in the private sector, we are in very serious financial distress because of the accumulation of unpaid bills. I think we have explained from NHIF, by the point it transitioned, we were owed about 6.8 billion. And we've transitioned to SHA. We've been providing services, and payments are being done, but to us, I think what we have received is about 50%. So there's build up.
What was the total amount that you were to be paid?
These amounts keep changing every other day because of claims
So in terms of numerics, how much was that 5%?
Not 5%, that is 50%, about half. We had the data we had put together, we'd collected from the facilities by the end of January.
Yeah.
We had been paid about 2.2 billion, and what we were owed was about 2.15 billion. So it's about 50%. But the payment, like I say, they are done on a monthly.
2.2 billion?
We had been paid about 2.2
billion,
but we had claims about 2.15 billion that had not been paid.
It seems less.
It seems more.
I'm saying it's about 50%.
So you have been paid 100%?
No. The total claims were about 4.4.
Yeah, that's what you wanted, yeah.
Yeah. So
because
I was accepting
you said,
what we've been paid.
Yeah.
So, but it's the data at that point, and I say it changes because every day patients are being admitted, are being discharged, surgeries are being done, claims are being submitted, and SHA is paying progressively every month. But what we've also found is that the claims processing seems to take quite a bit of time. So that's why the data in the hospitals might be very different from what SHA says. We paid 100%, we paid a very high percentage, or we paid all your claims. So the point I'm making is that progressively, given that the NHIF big debt has not been sorted out, and we still continue to provide services, and we're buying medicines, we are buying implants, we are paying health workers, and we owe suppliers, some of whom have stopped providing supplies. The distress continues to build up, because what we had expected is that the old debt would be sorted out even as the new claims are being paid, so that the accumulated liabilities are being sorted out, and hospitals have more cash to enable them to continue providing services.
Yeah.
So our major appeal, and we had an engagement with religious leaders and said, we are getting to a point where we may get to a halt, given the magnitude of commitments that we have every passing day, every passing month. Okay. And the appeal was, please pay what is the old debt from NHIF, even as and also improve payment rates for SHA. Yeah. Of course, the other challenge was the outpatient, which the chair was, as explained, maybe what they're trying to do. The concern was the amount of money released at any one point for the outpatient services is very little compared with the amount of compensation they used to get, put out together on a quarterly basis. And then there's the other big gap that we have. We used to have outpatient services covered in the hospitals. Today, that bit is not covered because I think the new structure was supposed to enable referrals from the primary health care to the hospitals. And it's when you are referred that the insurance picks up. So as service providers, you come to hospitals, even if you need admission, the outpatient part of the services, you really have to make a contribution directly. So our appeal is to enable us sustain the services.
Okay.
Through making regular payment and substantial payments getting through to the service providers.
Okay. Yes, Dr. Your point. I'll come to Lishanga.
So there are a few things that I would like to clarify, so that
including the delay in payment.
I thought we addressed on the issue of the commitment from the president on the NHIF claims. And for under SHA, I thought that we pay on a monthly basis. And as he has said, maybe the providers are the ones who might, what they see on the portal is different from what they receive. And that's being addressed as well, so that you see real time what you have claimed and what you have been paid. But the few issues that I want to address is on the issue of what Brian has raised. The payments from ministries, government, county, that's statutory deduction. And statutory deduction is mandatory by law. So if your employer doesn't pay, you will not get services. There are no two ways about it, because that's under the SHIF, and that's how the SHIF fund works. We don't want to incur in, to treat you on debt, because the providers will be up in arms tomorrow. So I rather tell them not to provide services than allow you to provide services as I become a debt collector. That's not the work of SHA. In as much as we will try following up on compliance issues. But the first enforcement is to deny you services and then now follow up with your employer why they haven't deducted.
So that includes civil servants, as the Act explains, both national and county?
Yes, it doesn't matter who your employer is. If it hasn't paid its statutory, you will not get services. And we have given Kenyans a place to check eligibility at sha.go.ke for them to see, has your employer paid for you? It will tell you categorically that you are covered or you are not covered. So on the second thing, there's no money for indigents at primary health care, because everyone is covered.
Okay.
Whether you are CEO, whether you are president, primary health care covers everyone irrespective of the social status in life. What government is supposed to do through the Ministry of Social Service is to pay for indigents the SHIF component. That's for people who can't afford to pay their premium.
So these are largely dependents?
These are largely the elderly, the vulnerable, orphans, the people who are identified, and that there is a mechanism that they use to identify those people, then budget for it, then remit the money to SHA. Then SHA now gives the cover to those indigents. It's not SHA that identifies who is an indigent. It is the Ministry of Social Services. The issue of moving up to the ECCIF, it's clear on how to move. So when you look at currently ICU,
okay.
We have been paying 4,500 as a cover, which was a bed rebate. Now, because we have received money for under ECCIF,
okay,
that moves to 28,000. So meaning, as long as you have paid your premium, okay, so your ICU daily rate will move from 4,500 to 28,000.
Okay. Okay.
Then for people with cancer, so there is also an extra 150,000 that have been set aside. Remember, all these things have happened because there was a financial bill that was withdrawn in the last financial year.
Okay.
So what we need to look at is going forward in this next financial year, how does government now budget based on for those two other funds?
Okay.
The last thing on Dr. Mwendwa,
yes,
and I think this Dr. Brian will agree with me, we need to have order when it comes to service delivery. We cannot have patients walk to level 6 hospital for their usual basic treatment. You are wasting the human resource at that level, okay, where you have professors, people who have specialized. So the focus is primary health care should be done at level 2, 3, 4. Mm-hmm. We have even added a 4 as part and parcel of just trying to expand before these level 2 and 3s come up and give us the services that we need.
All right.
So I think it's the right thing. That's what we have been taught in school. That's what we have learned over the years. That's what in any developing countries happens. You start from your primary healthcare facility, where you will get 85% of your health needs before you move into the higher levels.
Okay.
Let the higher levels focus on specialized services.
Yes, Dr. Let's then talk about the critical illnesses and shortly, because I'm looking at the benefit packages. And for example, yesterday, out of a total bill of 300,000, Dr. Daniel Chacha, the case which led to the protest of your colleagues in the profession, you only paid 30,000 Kenya shillings. For example, how does it work in such circumstances?
So for the first time, we have an explicit benefit package with a tariff. Mm-hmm. Previously, you did not know what you were covered for as an individual, unfortunately. Providers had different contracts with different prices, and they can tell you because I was part of it and I understood where the problems were. But now, we have a document that is in public domain that states what is the benefit and what is the amount. What I have gathered from that case is the person was in ICU. Mm-hmm. So the amount that is benefit for ICU was 4,500, which now has been moved to 28,000 because there is money that has been allocated under ECCIF. So meaning, the next time someone is in ICU, and if you are there for 5, because 4,030, that translates to around 6 nights. So now you will get 6 times 30, or close to 30,000, around 180,000. So it will move from the current 30,000 to almost 180,000. Why? Because under ECCIF, there's a benefit. But remember, there is a patient who goes to KUTRH for surgery, and the bill is 850,000. Mm-hmm. SHA pays the full 850,000. Why? Because that's how the benefit package is designed, that it pays for surgeries, it pays for certain things, and it states how much it pays for each. So it's not that I was in hospital, I was paid for 10,000. He was in hospital, he was paid for 800,000. So you don't look at what your bill total says, you just look at what was the benefit that you are entitled to for the services that you have gotten. And for the first time again...
For the remaining 270,000 then, was Dr. Chacha not entitled to other benefits as well?
That's now what the hospital... You see, it's not SHA that says, it's the hospital that claim. So they look at what is in the benefit package that they can claim. So they say this one, CT scan, tick. MRI, tick. ICU bed rebates, tick. Surgery, if it was done, tick. So that's how it's supposed to happen. Each hospital understands what they are supposed to ask. Then now what happens is, because this benefit package was at the beginning, we have an opportunity to expand that benefit package based on the resources that become available, based on the number of people that, as he has said, who register and contribute, that can be expanded.
We'll talk about other benefits because the package is very long, about 54 pages, and we'll look at other critical illnesses. Here, Dr. Brian, you are silent.
I just want to say some of the critical problems we have. One, I think the Cabinet Secretary needs to rein in her PSS, because part of the challenges we have now in the health sector is roadside declarations by the principal secretaries, which have made a bad situation worse. I'll just put it this way. As far as NHIF liabilities are concerned, the president has pronounced himself on it. He has made a commitment to pay. We don't expect the PS to come out in public and begin to contradict the statements that have been made by His Excellency the President. We don't expect that. Number two...
so let's hear what the PS, Harry Kimtai, said, and you proceed. I think he was in the county of Embu, to be specific, and this was his warning to healthcare providers if they decide to stop service provision.
The government came with these reforms is when they have woken up and realized, oh, give us our money, you owe us this much. Surely, where were they since 2016? Why do you protest? Why do you stop service? Yet you knew very well that you had, the NHIF had your outstanding bill since 2016. We've called them for negotiations, we've called them for engagement that prove to us that these are indeed true. So we are ready to pay. But they should not blackmail the government. They should not blackmail citizens by stopping offering of services. If they continue like this, it is obvious. They are also subject to renewal of license. So if you are not compliant, we also say, okay, fine. You offer service. You don't want to offer service to Kenyan in accordance with the Kenyan constitution and the Kenyan laws, then close shop. That's not the right business that you're supposed to do. So we believe that working together as stakeholders is going to solve our problems.
I honestly, P.S. Kimtai under the previous regime was in charge of livestock. I think he's not realized that he's now dealing with human beings. He's trying to deal with us like livestock. These statements are in contradiction with what the president said. The president acknowledged that the liability exists.
Yeah.
So for the PS to come and say that, where were you since 2016? This is utterly uncalled for. And we actually want the PS to retract those statements. In fact, in that statement, he seemed to suggest that those claims are fraudulent. And these hospitals, they are not even genuine. So I think that is really unfortunate. What we need from the PS and the CS, specifically from the cabinet secretary, you have an instruction to gazette a verification committee within 1 week. It is already past 1 week. If I was her boss, I would actually be summoning her to ask her why hasn't she delivered on my instructions. The other thing is a lot of things which we are struggling with in the Social Health Authority are actually things which the CS is supposed to issue regulations on. Let me give you an example. We have the Act establishes a claims management office. I don't know how Dr. Abdi is managing claims now. He's managing them.
He will respond to that.
Somehow he's managing them, But if you read the Act, Clause 35, it says there is established a claims management office. And some of the responsibilities of this claims management office include reviewing, processing, and validating claims. Another one is a key one, which we are discussing here, issuing pre-authorizations for access to care. That is the claims management office. Undertaking quality assurance surveillance in respect to claims. Another issue is sensitizing claimants. What Dr. Abdi is doing here is sensitizing claimants. He says sensitizing claimants on the benefits, the benefits packages, and on submitting fraudulent claims, preparing quarterly reports on claims. Today, as we are here, in fact, it goes on and says that the cabinet secretary shall make regulations for the better carrying out of the provisions. Now, as we are today, we have not seen the cabinet secretary issue any regulations to guide this claims management office. What we know is that SHA is conducting its claims management function somehow, which is beside what is provided for in the law.
So it's in contradiction.
It is basically the Act has not been operationalized in full, and therefore we are having hiccups even in primary health care. We are having hiccups in claims management. We are having hiccups on the issue of transition to the emergency. And I respectfully disagree with my colleague that the regulations for transition from shift to... I have a cancer patient right now who has stage 4 cancer. This patient is actually a civil servant. When you look at their limit, they have exhausted their limit because they have been on care. That is their limit under SHA, okay? But so this patient is supposed by the Act, because the Act says that on depletion of the SHA fund, transition, isn't it? Nobody really knows how this patient will transition to that emergency chronic and critical illnesses fund. In fact, what the hospitals are telling us, that within the portal of SHA, there is no way for them to transition a patient to the chronic and critical illnesses. This is an issue that, for me, is a failure of leadership, especially by the office that has been mandated to do this, which is the CS's office.
All right. So I'll come to Dr. Mwenda, but Dr. Abdi, about the claims management and the transition, could you shed more light on that?
Okay, thank you. I think let's just be fair to the CS, the Cabinet Secretary. Yes, there are one or two areas where the team or whatever that's required hasn't been done. But on the claim, it's in the regulations. If you open the regulations right now, you will see. And one of the things we were bashed about was what is in the regulations, which says that Social Health Authority may outsource. The word was may.
Okay.
And what we have done is decided not to outsource. Instead, do it internally. We have also done...
For the claims?
For the claims. So we have a whole department under our HR instruments, under the current program where we are doing recruitment and transitioning staff, which deals with claims. And it's called Claims and Benefits Department, which has a director. It has 2 deputy directors. It has assistant directors. So we are doing that currently as we speak, transitioning staff to the new structure of SHA. Remember, we had staff under NHIF. Now we have the new structure, which is different from what NHI's mandate was. So we have that department established under our HR instruments. It's the same department that's now doing all these things. Yes, they might not have been as adequately anticipated, but it is there. The regulations are there. What's supposed to happen is there. If you look at that regulation, you will even find the country has been divided into zones, 8 zones. Yes. If you open at the annex at the end of the regulations. So all these things which are in the Act, most of them have already been done. So what remains is just the appointment of the benefit team, benefit design team, which I am certain that there has been communication to the membership, the people who are required to be members of that committee, have received letters that they need to nominate. So
that's not the case?
No. What the cabinet secretary needs to take, we need, now in the case of Daktari who was Chacha, let me just put it this way. The law is very clear and the regulations that in case there is a dispute or an issue where you as either a beneficiary or as a provider, you have an issue with how your benefits have been managed or your claims have been paid, that you can complain to the Dispute Resolution Tribunal. Is there a Dispute Resolution Tribunal? There is no Dispute Resolution Tribunal. Why 6 months down the road, we have not seen action from the CS's office to set up a Dispute Resolution Tribunal? Why 6 months down the road, we don't have this Benefits and Tariffs Committee? And what process that my colleague here is talking about, people have been invited, is also being done in a very opaque manner. There is also the issue of the Primary Healthcare Advisory Council, which is supposed to have helped Dr. Abdi here with the issues of primary health at national level. Is there a Primary Health Advisory Council in this country? So all these ought to have been set up by... All these are supposed to be set up by the Cabinet Secretary. We have a lot of governance issues. Okay. I also disagree with Dr. Abdi by saying he has a Claims and Benefits Department. There is nothing like that in law. He only is supposed to have a claims management office, which is established. It has a clear mandate. Within that claims management office, yes, he's very right in saying may. But even in that may, there are also other caveats around the may. So we have issues around, and by the way, our concern is if they don't establish the claims management office and they delegate that task to third parties like the Digital Health Agency, I don't know which other company, they are going to be outside the provisions of the Act. And these are things which the Cabinet Secretary should be embracing immediately. Okay. Dr. Samuel Mwenda, I'll come to you, Abdi, on also the many questions that will be sampling. In this battle of lives and licenses, where do you stand?
Well, licenses are issued by the Kenya Medical Practitioner Dentists Council. Yeah. So that's a different body that I think deals with licensing. And SHA is dealing with financing. I do not see why, if we have some disagreement or conflict or matter we are pursuing in SHA should have anything to do with licensing. License should, there's a criteria based on which you are assessed, and if you meet the requirements as per the regulator, you are licensed. So I don't think there should be, what SHA does is accredits you to provide services. There's a process set out. If you're not doing it, as per the contract, you're not meeting the contractual requirements, how you can be maybe suspended or terminated from that relationship. So I do not think those really should be, that should be applied when we raise an issue about services. And in any case, what we are saying is that we are having difficulties sustaining quality services if funding is not flowing. We need to support each other. We have offered services to clients who are members or contributors to SHIF, and we're supposed to be paid to enable us to continue providing services to more. And if the system is working well, I think Kenya should be able to improve scope and quality of services to all of us. We can discuss other areas of improvement as we enable service providers to continue doing their services, provide their services as required. For those of us who are in faith-based, we don't have subsidies from elsewhere.
Okay. But then, Dr. Mwenda, the law then places Parliament at a very critical juncture, which is then its appropriation of money for primary health care and emergency and critical. So does the Parliament and parliamentarians, do they understand what really affects Kenyans?
Well, we expect Parliament to do it, to take his, undertake his mandate in providing the resources that is required. Of course, Parliament also does oversight through the relevant committee, the Committee of Health. But from the health sector side, we have to make our case for what resources are required. It's the health sector that knows what is the cost to provide these services. So our appeal as Kenyans and as service providers is that adequate resources should be provided. In fact, it's unfortunate the kind of case that you are citing, because this emergency chronic and critical illness fund should actually have been operational right from the beginning. Because ICU services are extremely expensive. 4,500 a day is really a contribution, a minimum contribution to what is the cost on a daily basis. So having adequate funds allocated to that kitty and getting it operational will enable Kenyans who require that critical service to receive it and not be asked to pay a top-up. Okay,
and that comes to the benefit packages you're talking about.
Yes.
But Dr. again, as you respond to that, because I'm looking at the long list of the tariffs to the benefit package under the Social Health Insurance Act number 16 of 2023, and to just cherry pick on what really bothers Kenyans in terms of illnesses, and I'm looking at the benefits entitled to beneficiaries. For example, looking at the critical care for admissions at intensive care units, ICU 35,000, HDU 10,000. That's again for ICU it's up to 14 days, HDU up to 10 days. But of course, depending on the number of times that you'll spend there, that can lead to a scaling up of the amount. So for cancer, I was looking at, for instance, preparation for the storage of a body in a mortuary, 500 per day, limited up to 5 days. There are also other instances. I'm trying to fish out the cases of cancer screening, which was there about inpatient services for management of diseases condition while admitted, and that is at level 3, level 2,400, admission of up to 50 days. So these benefits packages, screening for common cancers, breast, cervix, prostate and colon, level 2 to 6 with capacity. For HPV, it's 3,600, PSA 1,500, stool for occult blood, 400 Kenya shillings, and chirotherapy at 3,000 Kenya shillings. For prostate cancer will only be covered in males of over 55 years, and for colon cancer, screening will only be covered in males over 40 years. So in consolidation then, how can this be upscaled given the healthcare needs of Kenyans?
So there's usually there's an established committee to begin with. But more importantly, the upscaling is dependent on many factors. So the first factor is what is the burden in the country? What are the resources that are available? Because, you know, NHIF was collapsing because of giving benefits that outweigh the premiums. That is what we call living beyond your means. So we have to have a proper, scientifically determined process on how to go about it. And one of the things that the Act provides is when the committee is established, even ordinary citizens can petition and say, the money you have allocated for this is lower, can you increase? And then the committee looks at the data, the consumption.
Is that committee in existence?
That's what's being established.
Okay.
And that's what now my brother is saying. Yeah. It's being done opaquely. But it's not being done opaquely. What's happening?
Public participation.
No. The regulations are very clear on who should be in that committee. It clearly states where it should be located, who should be the chairman, who are the members, the qualifications. So there were letters that were sent to those groups. So civil society is represented under HENET. So they have a seat. So the public basically have a seat in that panel. Providers have a seat in that organization.
Is it going to be Dr. Brian Lishenga?
I don't know. If he meets the requisite qualification as per what is in the regulations, and the consortium accepts, because currently even at the board level, we have similar structure where there are different organizations that send a representative, and I'm sure Brian has received that letter I received sometime last year to nominate 2 people, where I did not nominate myself. So it just depends on, so what happened is some of these organizations actually sent people who are not qualified. So the process has taken a little bit longer than anticipated, because they need to understand that these are clear instructions on who can sit. So on the issue of ICU, you know the beauty now, because you are able to see a benefit and tariff, explicit. Previously, did you know what NHI was covering and how much it was covering? Even for ICU, it was not covering anything. It was covering 3,000 shilling. Or the rebate for that hospital. If that hospital's rebate is 2,500, you will get 2,500. Now, we have moved it from the 4,000 to 28,000. Our vision and dream and ambition is to pay even 100,000. That is our vision. But we have to be realistic, and we have to live within the means and the resources that's available to us. Otherwise, what will happen is we will do things to please people. Then what happens is he will provide service, then I am unable to pay him. Why? Because the money I have collected is not enough for the promise that I have given to Kenyans, and they go and get services. Then I run into debt problem. So on the issue of claims management, just to clarify to Brian, establishing an office does not mean it's a physical office. It is the carrying out of that work. And the carrying out of that work under our instruments is clearly stipulated. We have a whole department called Claims and Benefits. A whole department with almost 50 people allocated. From a director, as I've told you, to deputy directors, to senior officers, principal officers.
Okay.
So we have established,
yes,
and we are doing the recruitment.
Yes.
So some of those positions might come to external adverts, and I hope people who qualify will apply for those positions.
So, Daktari, before we sample the feedback and also respond to questions by Kenyans, I'm sure you have gotten note of the Auditor General, Dr. Nancy Gathungu's audit report on the Social Health Authority and the technology digitization system, where she cited unbudgeted procurement, no procurement plan, and competitive procurement, violation of the Constitution in that regard, and defined scope of work. And she further pointed out that 2.5% of SHA member contributions, 5% claims from health facilities, 1.5% track trace solutions, all totaling up to 111 billion in 10 years. On a daily basis, this money is ending up in escrow account. Are you in control of the system?
First of all those things that you have mentioned, none of them is accurate.
What Auditor General mentioned?
Yes,
yeah.
And none of them is accurate. The first thing that you need to realize is that audit is the Ministry of Health, State Department of Medical Services. It's not for SHA. Let's just clarify on those issues. Two, it's illogical to pay 2.5% when our administrative cost is 5%. It doesn't even make sense because you will not be able to have any service delivery. That needs to be very clear. So it's very unfortunate that when you look at something and then you can clearly see none of it is accurate, then you ask yourself and wonder how, because I have seen the responses to the questions of what the Auditor General asked. Actually, none of them was captured in her report because you see the expectation is when you ask people questions, you either verify their responses and then come to a conclusion. But I can categorically tell you there's no 2.5% that's going to any escrow account.
Yeah.
All the money for SHA is in SHA's account. All the claims that come go to the providers. And it comes only from the providers as we speak.
Okay.
So there is no, and SHA retains 5% for administrative purposes.
Okay.
That's to pay salaries.
Okay.
That's to pay for the cost of running the organization.
All right. So 2.75% deduction funds primary healthcare and emergency critical fund. The money ends up in SHA bank account. Then the movement of money subject to the law, Parliament will do the appropriations, then come to the National Treasury. But she was very specific, Daktari, on the procurement of the healthcare information technology and digitization system to run the Social Health Authority.
So let me again clarify even further, because you have given me this opportunity. The digitization is as per what the law has said. If you look at the Health Act, under section, the Health Act of 2017, under section 15, paragraph 102 to 105 or 6, it talks about digitalization of the health sector. And it clearly states that in 3 years' time, the Cabinet Secretary shall form this digitization. So that would have been 2020. It was late by 3 or 4 years. So this is digitalization of the whole health sector. The 104 billion that people talk about this digitization is not for SHA. It's to digitize the whole health sector. The whole health sector includes giving hardware and software to all 7,000 public hospitals. And if you have gone around the country, you will realize the adoption of the health information system and digitization, it's the public sector that is lagging behind. The second thing that you need to realize is this system is supposed to create a HIE that connects Brian's facility, Mwenda's facility, and a public facility that allows them to speak to one another. So that if you as a patient moves from this hospital to the other, you don't need to carry your file. You don't need to carry all your documents. Okay. At this facility, you are able to see. So the component for SHA is very minimal. It's the ERP. That's the only thing that SHA's component in this whole digitalization is. And when you look at the 104 billion over 10 years, means it is around 10 billion a year. And government is putting 0 shilling in terms of resources, allocating any money to this program. Okay. So it is for software as a service. So on utilization is where now you charged a fee for it. Okay. So it means that it's more than what people just keep on tying to SHA. So the other thing that if you look at on this same digitization is supposed to do is to do track and trace for medicine. There is a report or a study that was done in Kenya by obstetricians and gynecologists. Out of the 17 syntocinon, the medicine that's used to stop bleeding women when they give birth, 11 of them were fake, did not have the required component. That means we are giving choka to our mothers, hoping they will stop bleeding, but in the end, keep losing their lives. But when you now take that medicine and go to the manufacturer or the distributor, what do they tell you? This is not from us. Why? Because no one has ever captured these drugs when they came into the country. So you have many fake drugs that come into the country, many substandard drugs, which you cannot know even to recall. Today, if you need to recall a medicine from any of the hospital, you wouldn't know whether it's in this hospital or whether it's in this hospital or it's somewhere in public, because there's no one who is tracking and tracing these things. So this digitization is way bigger than what people keep on referring to every now and then. And it's very unfortunate that we have come to this level of misinformation and disinformation. Okay, then in regards to that still, I'll come to you, Dr. Brian. If you say about the money, it's not going to an escrow account, then if none, how will the consortium get their money? Now that's what the DHA is supposed to do. And it's supposed to be something that is done in regulation, and they will do what is paid as fee for service. So one of the things... so who is that person who's doing it? Under the Digital Health Agency. Okay. Under the Digital Health Agency, because this system, that's why we have created this whole organization that is now to be the custodian of digitization of the whole health sector. So meaning that we move away from paper trail to digital footprint for everything that we do, including who has received services, what is the disease burden in this country, because you also don't want to keep on depending on donors to tell you that you have HIV burden here or you have teenage pregnancies. Okay. This is real-time data that will be available to the country for purposes of planning on a day-to-day basis, rather than waiting for us to do KDHS, the Kenya Demographic Health Survey, which is done every 10 years, or is it 5 years? And then now create a policy. Yes, thank you. Let's sample the feedback, and I'll come to Dr. Lishenga and Dr. Mwenda. Here's what you're saying on X. The hashtag is Citizen Daybreak. The SMS code is 22422. The big question is, Sam Masika says, has SHA made healthcare better for Kenyans? We have too many explanations that might not help the sick. The spoken efficiency should trickle down to the villages. Otherwise, hii ni kizungu mingi. Yes, yes. San Nixon Degura says, SHIF is not working well for outpatients, and this is training parents after Edo Afia that took great care of students, especially boarders, was scrapped. And can contributing parents be refunded the money they spend on registered pupils?
Janelle Lazaro says proprietors of SHA can't even account for the total amount they collected from Kenyans. So far, these things still need some kind of panel beatings. Government should prioritize culture of proper consultations. Bob Otieno says the government should suspend SHA and iron out concerns raised by Kenyans 6 months after the healthcare scheme was rolled out and bring all stakeholders on board for a proper implementation for it to be successful. Ras Bashir Were says the Ministry of Health must be held accountable for every shilling spent. Wastage and mismanagement in a critical sector like healthcare are unacceptable, especially when Kenyans are struggling with poor medical services. Parliament must demand full accountability. Frank Orinde says the SHA system is a disaster. Kenyans are paying for price of a rushed-up broken system by the government. The state failed to plan properly for this project. They even failed to run a pilot that would have helped uncover the challenges, and now patients are turned away. It's sad. Deshmo says systems don't steal, it's humans who do. What they should have done is make the old NHIF system more secure, a few updates here and there, but what stops the new overpriced system from the same human error? Yes, Dr. Lishanga.
Yeah, so I mean, everybody in the Ministry of Health knows what is ailing this transition. One, they have not done enough work to ensure they have healthcare provider goodwill. Two, they are struggling with the public sector goodwill. On healthcare provider goodwill, I will tell my brother here, Dr. Abdi, that it's very simple. So simple, Chairman. Just give a date for settling NHIF arrears. Just give the date. You just say, on this date, the hospitals owed less than 10 million shillings, check your bank accounts. We finish with that. Okay. And then this verification, the issue of verification of claims, I just want to advise the chairman of the board that please ensure that our colleagues, you know you came from our side, eh? Ensure those guys who don't understand how things work, don't label legitimate claims as fraud, because there seems to be a push here to say that if you had claims of, and like you, I also appreciate that there are indeed cases of fraud that were happening. And we, even in our case as an association, as RUFA, we went out and published an anti-fraud policy that all our members have to subscribe. Okay. And any time SHA shows us that a member of the association is engaged in fraud, we suspend them from membership or even expel. But let us not use the excuse that if you are owed more than 10 million shillings is fraudulent. So please, how do you buy provider goodwill? Okay, or get it? Let me just finish this. Yes, point. Please. What SHA needs to do is ensure that historical liabilities are settled. Let's not have a ping-pong around that. Secondly, you have started doing some work on primary health, but we still have a way to go on primary health. Can we fix any issues around primary health, including the governance structures that we are mentioning? Thirdly, on the issue of ordinary Kenyans, what ordinary Kenyans need to experience is value for money. Once providers are aligned, Kenyans will go to hospitals and experience this reform, and they will now start to shift. But also on that issue of Kenyans, the issue of premiums, please have the flexibility to look at whether proxy means testing is the way we should keep going, or if you can have a mixed model somewhere in between, okay, an earmarked tax or something like that, so that you can get back Kenyans' goodwill. Okay.
Yes, Dr. Mwenda, the final comments.
Well, the service providers are committed to provide services, quality service to Kenyans. But based on the arrangements they have with third-party payers, including SHA, we want commitment on the part of the payers. When we provide the services, the payments are done on time. We want a system that efficiently works. I also agree with my colleague, Dr. Brian. The burden from the previous scheme, NHIF, which also a government-run institution, okay, really should be settled. We appreciate the commitment about 10 million, yeah, but as FBOs, we raised a concern about that. Because some of the hospitals that are owed a lot of money are those which provide a wide range of very specialized services, which are extremely expensive to provide, including very complex surgeries, cancer treatment, and so on. Okay. And they should also be included proportionately, because otherwise we risk losing some of our best. And we need to make sure that the Kenyans, when they go for services, they experience a much better benefit than what they were experiencing before from NHS. That's what they are comparing.
Okay. Thank you. Much appreciated, Dr. Samuel Mwenda, the General Secretary, Christian Health Association of Kenya. Thanks for your time. Dr. Abdi Mohammed is the chairperson of the Social Health Authority.
You want me to tell Kenyans?
No, we spent a lot of time on
no, just to just tell them that please register *147#. If you have a problem, call 147 to be solved, your issues. But more importantly, please pay. And I want to now promise Brian that the proximity testing plus the issue of insurance premium financing will be up and running
Thank you.
by the end of April latest. On the issue of the old debt, there's nothing beyond what SHA has said that I can commit. That is the highest office, and we will implement that instruction.
And there are many questions, so some I have forwarded to your WhatsApp, so you will respond to them. Okay. And Dr. Brian Lishenga is the chairperson of the Rural Hospital and Urban Hospitals Association of Kenya. Thanks for your time, doctors, much appreciated. Up next is Health and Lifestyle. Safina Chiengoma will be with you in the next 1 hour. Thanks for watching. Good morning.